करेंगे
क्या
मतलब जो अपने आप चलते हैं ना स्लाइड से वो कैसे क्या करेंगे इसको।
स्लाइड्स कहाँ है तुम्हारे?
कहाँ गया मेरा यार।
डाउनलोड कर
ये
लिया तुमने?
ये हाँ ये कंटेंट ओनली ना, शेयर करते हैं। अब ये उसमें कैसे जाएगा, स्लाइड से मोड में कैसे आएगा।
ले ले।
आ गया ठीक।
हाँ।
Neeraj, I'll just introduce, and
Yes.
by then you can fix your slides also.
Yes, ma'am.
We are live.
Hi, good evening. After a long hiatus from the national conference, we are now back to our classes. And to begin our session, the first class is going to be by Dr. Neeraj on management of status epilepticus. Over to you, Dr. Neeraj.
Good evening to all of you, ma'am. So today class is a management of status epilepticus. Shall we proceed, ma'am?
Yes, please.
So it's a case scenario of 27-year-old female patient presented in emergency department for witness convulsion. She had suddenly exhibit stereotyping abnormal behavior followed by a head deviation to the right side and a generalized tonic-clonic seizure which lasting approximately to 5 minutes. She had a history of fever 3 days back, vomiting and diarrhea 2 days back. She also had a history of abnormal behavior since 5 to 7 days with a no history of any chronic illness in past. On arrival in ER, she was unconscious with a low GCS of even V1 M3. BP was 158 by 78 mmHg. Heart rate was 132 with SpO2 78% of room air. With intermittent seizure episode for which she got intubated and kept on ventilator support. Now she is not attaining consciousness in between the seizure episode, not responding to multiple IV anti-epileptic drug, including the second line of drug. Her vitals was BP was 146 by 80, heart rate by 84, temperature afebrile, pupil bilaterally reacting to light, normal size with intact oculocephalic and corneal reflex. She was shifted to an ICU with anti-epileptic infusion of IV midazolam at the rate of 5 ml per hour. So, ma'am, what is the most common differential diagnosis in this patient? She might be a case of sinus infection infected by viral, bacterial, or tubercular. It might be a case of
Dr.
TB.
Neeraj,
Yeah, ma'am.
before you come to discussion of etiology,
Yes,
how
ma'am.
will you take care of immediate acute care of this patient? How will you go about?
Ma'am, we have to start with ABG. Ma'am, this is the diagnostic approach or diagnostic workup for a patient. All the patient obtain IV access, monitor vital sign.
Yeah, so monitor vital signs ABC. How will you go about? What is the score of the patient?
Ma'am, it's a even V1 M3, ma'am. It's almost about 5. This is 5. So we have to intubate the patient first.
Hmm.
To take care of ABC airway breathing circulation, we have to maintain all three.
Hmm. And then next, what do you do?
What, ma'am?
So you've done ABC,
Yes, ma'am.
and while you're doing ABC, what will you take care of?
Ma'am, we will
You
take
said
a
you've obtained your IV access, then what will you do?
ma'am, we have obtained IV access. We send the appropriate investigation to the patient or
Okay.
monitor vitals. We plan for a head CT lab investigation. We plan.
So is the patient actively seizing or not right now?
Actively breathing, ma'am.
Actively seizing, seizure is going on or not?
How ma'am is going on, ma'am? Seizure is going on, so we have to give a first line of drug, but patient is not responding to first line of drug or second line
What
of
is your
drug.
first line of drug?
Ma'am, IV lorazepam or midazolam, benzodiazepines.
Okay.
The patient is not responding, so we have to use the infusion also.
What anticonvulsant have you given till now?
Ma'am, benzodiazepines we have already given, but patient is not responding. We have already given the
Benzodiazepine you gave, agreed. Anticonvulsant.
Anti-convulsion ma'am, we already given Levipil 1 gram
Okay.
IV stat.
That comes to how many mg per kg?
Ma'am, 40 mg I think per kg dose is Levipil ma'am.
Okay.
4 0.4 sorry 0.1 mg per kg ma'am, 0.1 mg per kg.
So you
Maximum
give 40 mg, then
the patient is still having seizures ma'am.
hmm. So what would you do? Remember, you can't take the patient for imaging unless you control the seizure. You cannot take a seizing patient for imaging.
Yes ma'am, definitely ma'am, we have to control the seizure first and then we'll
Huh.
send the patient.
So start from there, no? What you're going to do.
Okay ma'am. So we have to control the seizures ma'am by using the line of treatment. A patient is not is responding to benzodiazepine, then we'll go for the second line of treatment. Patient is still not responding to this second line of treatment, then we add some anesthetic drug to control the seizures, and then we'll send the patient for further investigation.
So can you, do you have slide to define the terms? What is status? What is refractory? What is super refractory?
Yes ma'am.
Start from there.
uh, Ma'am, basically, definition of seizure, the old definition of seizure is seizure lasting longer than 30 minutes or 30 minutes of recurrent seizure without return to baseline uh, neurologic status between the event. This is the older definition of seizure. Now it has been largely replaced by a operational definition, which is a 5 minute duration of continuous seizure activity or two or more seizures between them, in which there is incomplete recovery. Now the ma'am, refractory status epilepticus definition is status epilepticus resistant to one line of benzodiazepine. Status epilepticus,
Continue.
what ma'am?
Continue. Continue.
Ma'am, status epilepticus resistant to one line of treatment like benzodiazepines and second line treatment like phenytoin, phenobarbital and valproic acid, anti-epileptic is labeled as refractory status epilepticus. Nearly 40% of status epilepticus are refractory and has mortality of 16 to 39%. And super refractory status epilepticus is defined as the status epilepticus that continue or recurs 24 hours or more after the onset of anesthetic therapy, including those cases where status epilepticus recurs on the reduction or with the withdrawal of the anesthesia.
So in your scenario, you
Yes, ma'am.
have now given benzodiazepine, you have given levetiracetam,
Yes, ma'am. Already
and
given.
still the patient is seizing.
Hmm.
So which category of seizure has she fallen into?
Refractory status epilepticus.
So she is in a refractory seizure.
Yes, ma'am.
Now what will you do? What will be your drug of choice?
Then will we plan for some anesthetic drug choice, ma'am, like ketamine
Yes,
or
while you're doing that to break the seizures, you also said levetiracetam you've given only 40 mg per kg.
yes, ma'am.
You can go up to 60.
Okay,
So your dose can still be increased. One of the biggest what do you call drawbacks why the seizure becomes refractory seizure is before reaching the hospital and in the ED, doses are not optimized. You give
okay,
suboptimal level of anticonvulsants and the patient continues to seize. So here you still have room to increase your levetiracetam dose.
okay, ma'am.
Okay, continue.
Now, ma'am, some new form of refractory seizure status, the new onset of refractory status epilepticus is NOS. It's a very rare condition. Prolonged refractory seizure with no cause in otherwise healthy individual. It might be autoimmune encephalitis, the most common cause, under
No,
identified
you
neural
haven't
disease.
you haven't understood that.
Yes, ma'am.
So your patient has come with seizure. Your
Yes, ma'am.
patient can fall into two categories. Either
Okay.
he already had, she already had an already diagnosed patient of epilepsy or seizure coming to
Yes,
you
ma'am.
in status. What is the commonest cause?
Ma'am, as per the patient age is, if patient is too young age and there is no history of previous
No,
trauma.
not age. In common parlance, the commonest cause of a patient on anticonvulsant drugs coming with seizure is
Missing dose, ma'am. Patient forget to
yes,
take their.
yes.
Yes, ma'am.
So you have to find out whether that is happening.
Yes, ma'am.
If the patient has never had seizure in their life and
Yes,
is
ma'am.
coming to you for the first time and is already in refractory seizure, that is new onset refractory seizure.
See,
It is
ma'am.
not a new category.
Yes, ma'am.
So NOS is new onset refractory status
Seizures.
epilepticus. Compare the two. Which
Okay.
will be easier to treat?
Okay, ma'am.
Do you know?
Yes, ma'am.
Which one is easier to treat?
Ma'am, I think Norse is easier to treat.
Anybody else in the group wants to say? NOS has a worse prognosis. And
Okay.
literature says most of the time the new onset seizure becoming into refractory seizure, the underlying problem is autoimmune. And in
Autoimmune.
fact, in these NOS patients, as you start the anticonvulsant drugs, you also start immunosuppressions out way before, way upfront, you start immunosuppression as well.
Yes, ma'am.
And these are very difficult to treat, and the prognosis is also bad. What is another small entity within NOS?
Ma'am, fires. It's a febrile infection
What is
related
that?
epilepsy. It's a, ma'am, febrile infection related epilepsy syndrome.
Yes. Even that has a very, there you'll have to think of all the infective etiology as well.
Yes, ma'am.
Okay, continue. So you've told about refractory seizure. What is super refractory?
Ma'am, super refractory seizure defined as the status epilepticus that continue or recur beyond 24 hours or more after the onset of anesthetic therapy.
Yeah. So you have given one of the anesthetic agents. So ketamine would also come in that. And then when you start, either after administering that, he continues to seize for 24 hours, or you've had a burst suppression, and then
Yes, ma'am.
you've started weaning the drug, you will again develop a
Seizures.
super refractory seizure.
Super refractory seizure.
Okay, now you continue with your slides.
One is, ma'am, is prolonged refractory status epilepticus that persists for at least 7 days despite the
No, no,
epileptic
you go
management.
back to your patient. We were at your patient. We
Okay,
were
ma'am.
doing ABCs.
So the ma'am now ma'am, what is the most common differential diagnosis in this patient? It might be sinus infection, autoimmune encephalitis, cerebral malaria, Japanese encephalitis, metabolic or electrolyte disturbances, sepsis associated encephalopathy, acute toxin associated encephalopathy, structural sinus causes, or acute gastroenteritis related complication, or the febrile seizures in case of child. Now, the general physical examination of patient in this patient, the patient is unconscious, intubated on mechanical ventilation with 50% FiO2 on ACVC mode. GCS was E1VT M3 on sedation. Pupil was bilateral equal and reacting to light. Tongue bite present, suggested of two seizure before intubation. Urinary incontinence present during the seizure episode might there. Rise to and falling inserted already in the ER with central and exit done. Vital was stable with slight rise in body temperature. No sign of head trauma, fracture, or any kind of assault injuries there. Average build of weight around 55 kg and head or height around 152 centimeter. No sign of rashes over body, neck stiffness, or had a fever of history. Hydration status was dry mouth with poor skin turgor, suggestive of some degree of dehydration. Her ABG show respiratory acidosis with mild increased lactate value and no sign of toxin abuse like alcohol, smell, or needle marks in body. Pupillary clue like pinpoint pupil or dilated pupil is not there. No sign of pallor, icterus, or edema or this cyanosis. Blood sugar was normal on arrival in ER. These are
Okay.
the general physical
So wait,
examination of
wait,
patient.
wait. So, if you were at the ED, what would the first investigation be? Someone coming with seizure. Let's get practical. Do a
Uh,
GRBS.
yes, ma'am.
Blood sugar,
Yes, ma'am. Blood sugar, ma'am.
both
Hypoglycemic
high
event,
and
ma'am.
low can cause.
Can cause seizure, ma'am.
How
Electro
does high cause?
high blood sugar.
How does uncontrolled high sugars cause seizure?
Don't know, ma'am.
It can cause de novo new seizure, or
De novo new seizure.
in an existing patient, the threshold for seizure is reduced.
Okay.
And even on the same dose of the drug, patient may still continue to seize because the sugars are high.
Okay, ma'am.
Okay, so both things can happen. You
De
know
novo,
how
de novo
low
new
sugars
seizure.
can also cause seizure. Then
Okay.
toxicology you already mentioned,
Already mentioned.
and infections. One more lab investigation you missed is patient is coming in status. So rhabdomyolysis is very likely. You should send a CKMB or CPK also.
CKMB, ma'am, we already sent, ma'am. We mentioned here in these laboratory finding. We mentioned, ma'am, creatine kinase is borderline. Low
Hmm.
blood sugar was low, hypoglycemia, hyponatremia may precipitate seizures. These are the laboratory finding find in my patient, ma'am.
And you have to do all the electrolytes.
Ji, ma'am. That's right. So, ma'am, on systemic examination of the patient, GCS we can't assess because of this sedation. Persistent low GCS may cause severe brain injury. People are bilaterally normal side, normal acting, corner reflexive or normal. Higher mental status usually not accessible in seizures like patient. Cranial nerve examination it's limited due to patient level of consciousness and active seizure activity. So the reliable testing is typically restricted to the brainstem reflexes like pupillary reflexes, corneal reflexes, or the gag reflexes, and these all are the normal in this patient. Power is not accessible during active seizure activity. In motor system, ma'am, during seizure, patient having tonic stiffness and clonic jerk movement. In post-ictal phase, patient may become hypertonic, most common, or maybe hypertonia, ongoing seizure activity. Reflexes
So
like
most of these tests cannot be done. Move on.
okay, ma'am. Ma'am, cardiovascular system patient heart rate may be more than 100 or more than 10. Might be patient having tachycardia, blood pressure is more than 140/90. Maybe patient having hypertension and no active arrhythmia on monitor. Respiratory system patient having bilateral air entry equal, no congestion and no cramps there. Regular breathing pattern, maintain 99% SpO2 and 40% FiO2. No sign of aspiration. Abdominal examination per abdominal shown soft and bowel sound is there. No hepatomegaly, no splenomegaly. Sign of dehydration might be there because of history of gastroenteritis persists. Musculoskeletal system, there is no sign of injury, fracture, or muscle tenderness present, but tongue bite is still there, ma'am. Now, ma'am, coming to the radiological imaging, a head CT should be considered for all the cases of GCS
No,
epilepticus,
you
ma'am.
don't tell us what is to be done. What was done for your patient and what were the findings?
Okay, ma'am. Now we have to done a CT scan, ma'am, in my patient. और CT scan, ma'am, grossly normal, ma'am, क्योंकि in normal seizures patient में there is no significant finding in CT scan. Just to rule out the any surgical causes like trauma or maybe tumor or maybe any kind of intracranial hemorrhage there, ma'am.
Okay.
MRI brain we also did, ma'am, which in both the sequences, ma'am, like D1 sequences and the flare, and we find a significant finding in my patient like hyper intensity, increased signal brightness in affected area in T2 flare images, and a low value of ADC mapping we will seen in D1 restricted images. Cortical swelling might be there in ma'am, and
Are you justified in doing these images without contrast?
no, ma'am.
Why? What additional information will you find if we had done with contrast?
We use contrast, ma'am.
Did you? In that case, why did you give contrast? What were you thinking for? Contrast would be a great idea only if you're thinking of an infective etiology,
Okay.
some abscess or something. But your
Okay.
patient didn't have any fever, no?
Yes, ma'am. But ma'am, she
Yeah,
had a history of fever 2 3 days back.
is it? If infection is not on the card, your patient already had raised CPK, so you are justified in not giving contrast.
Okay, ma'am.
So it depends. If the fever is an infective etiology is the cause of seizure, then you should be doing with with the contrast. But why did you do CT and MRI both?
Ma'am, because initially we found that might be patient having some previous brain injury or maybe some sinus infection might be there. So we'll do a CT scan. Okay, it's a very fast मतलब process, ma'am. इसलिए.
All right, go ahead.
And ma'am, uh, these are the laboratory finding my patient, ma'am, like low blood glucose, hyponatremia, hypocalcemia, hypomagnesemia, ABG show respiratory acidosis with mild lactic acidosis, CBC revealed a raised TLC count with mild thrombocytopenia, RFT and LFT was normal, creatine kinase was in borderline. We also do, ma'am, CSF findings, so mild lymphocytic pleocytosis with the mild elevation of protein, and we'll
Why are you not considering a viral etiology? Why are you going to autoimmune encephalitis? CSF shows mild lymphocytic pleocytosis, elevated protein.
because ma'am, ma'am, we have a CSF finding like auto antibodies is also there, ma'am. That's why.
That wouldn't come on the first day, no. So the sequence in which the patient came, you did CSF and you found this. Why didn't you consider viral? Because you had fever also, almost normal CT scan, and almost normal CSF with just lymphocytic predominance.
Yeah, ma'am. Yes, ma'am.
Did you give any antivirals?
No, ma'am.
Okay. Go ahead.
Ma'am, we'll find an auto antibody in CSF finding, so we'll suggestive of autoimmune encephalitis. So we have to need some autoimmune panel also to find out some anti-NMD receptor antibodies which indicate NMD receptor encephalitis, which is the most common cause in, which is most common in autoimmune encephalitis in the young female. So we had a clinical clue in the history like fever or behavioral changes or the psychosis feature, autoimmune instability, decreased consciousness, and the antibody finding the CSF is anti-NMD receptor Ig positive antibody. And then when plan for the EEG, we have to plan an EEG for the patient which show a persistent rhythmic epileptiform activity or burst suppression pattern we'll see after treatment with anesthetic agent. So this is a picture of persistent epileptiform discharge in the EEG, and this is the burst suppression in EEG after the anesthetic agent. And this is the typical extreme delta burst pattern in autoimmune encephalitis in EEG patient which show a high amplitude rhythmic delta activities of frequency 1 to 3 Hz superimposed with fast beta activity like frequency of 20 to 30 Hz, ma'am.
Okay, let's move to management.
Yes, ma'am. Now the ma'am, now the management part, the status epilepticus is a medical emergency and it must be treated immediately in a critical care setting. Its mortality rate is 20%. There is a pharmacological intervention more effective at early state of status epilepticus than and after the delay. So we have an aim of termination of status epilepticus first, then prevention of seizure recurrence, and then the management of precipitating causes and the management of the complication. So we have an approach of diagnostic workup. With all the patients, we have to obtain IV access. We monitor the vital sign like ABC. We send the patient for CT or MRI. We have to send a lab investigation like blood sugar, CBC, renal function, calcium, all the electrolytes and the anti-platelet drug levels. We'll also plan a continuous EEG monitoring, preferably for non-convulsive CS like patient. Consider brain MRI. We have to consider lumbar puncture also. We have to consider toxicology panel also, and the other relevant investigation as per the need. Now, ma'am, EEG is very important. Initiated as soon as possible after diagnosis of status epilepticus, optimally within the 1 hour. During the treatment, the ECG should be reviewed immediately and then periodically until status epilepticus has been controlled or a bus suppression record is induced. So, the importance of EEG in status epilepticus is to confirm the diagnosis, help guide therapy escalation, monitor the response of treatment, and detect subclinical seizures. Indication of EEG monitoring is persistent altered mental status, patient having post-convulsive phase, suspected non-convulsive status epilepticus, and the refractory status epilepticus. So these are the some indication of continuous EEG monitoring in ICU, like in case of stabilized seizures or status epilepticus.
But is it proven continuous EEG makes a difference to the outcome? Has it proven? Theoretically and physiologically, what you're saying makes sense.
Yes,
But
ma'am.
has it been shown?
Ma'am, it's not a proven, but ma'am, it help to confirm the diagnosis or to help to guide the therapy. So we have to do a continuous EEG monitoring in in case of refractory seizures, ma'am.
It is not in the guidelines yet. It has not shown to
Okay,
make any long-term effect or affect the functional outcome. But that's more because not many people are able to do it.
okay, ma'am.
It's like ICP. It makes sense that if you monitor your therapy with ICP assessment, it will be better. But not many people are doing it, so it's not established. Same goes good for EEG also.
So, ma'am, continuous EEG monitoring is not important right nowadays.
Pardon me?
Ma'am, continuous EEG monitoring is not important. Is as per your
It
session, it is
should
not
be, but
important.
it is not a grade one guideline as such, recommendation as such.
Okay, ma'am.
So when you say that you need EEG for diagnosis, no, it is not like that. Patient may have convulsions, and if it is persisting and doesn't regain consciousness, you have to think of it. In an unconscious patient whom you cannot see convulsions, and you think it could be a subclinical seizure, there you will need. But again, has it going to be a continuous one or intermittent one? It is upon the availability.
Okay, ma'am. So, ma'am,
Just one second, before you move on to this algorithm, if you do not have EEG, any other bedside tools can help you detect seizures?
yes, ma'am.
What?
Ma'am, during seizure, patient hemodynamic maybe change or is physically see the patient like some tonic clonic or the some kind of facial
It is
movement.
subclinical.
Subclinical seizures might be difficult to find out, ma'am.
There are. So this is one thing you can go by. This is you are trying to sedate the patient and this is going high. Obviously, something is happening.
Okay,
The NIRS is another tool.
okay,
In
ma'am.
fact, the way the NRIS is being sold is one of the things is you can pick up non-convulsive seizures based on it.
Okay, ma'am.
Yeah, continue.
So, ma'am, this is the proposed algorithm for convulsive status epilepticus treatment as per the timeline guideline. Like first, 0 to 5 minutes called stabilization phase, in which we have to stabilize the patient airway breathing circulation. At the time seizure from an onset, monitor the vital signs, assess the oxygenation, give oxygen to the patient, consider intubation if respiratory distress is there, initiate EEG monitoring, collect finger stick blood glucose level. If there is a low glucose less than 60 milligram, then we'll give 100 milligram thiamine IV, then 50 ml D50 IV in adults. In children in more than 2 years of age, we'll give a 2 ml per kg D25 infusion, or a children is less than 2 years of age, we'll give 4 ml per kg D25 infusion. Attempt IV access and collect all the electrolytes and send all the laboratory investigation along with the toxicology screening panel or anti-conversion drug level in stabilization phase, ma'am. Now, if patient seizure persists, if it persists, In next 5 to 20 minutes, we will call the initial therapy phase. We'll start with the benzodiazepine, the initial therapy of choice. Choose one of the following three equivalent first line of option, like intramuscular midazolam will give more than 10 in more than 40 kg individual will give 10 mg, or 30 to 40 kg individual will give 5 mg midazolam single dose, or will give an intravenous lorazepam 0.1 milligram per kg dose or maximum 4 milligram per kg dose, and is may repeated one. Intravenous diazepam will also give in a dose of 0.15 to 0.2 milligram per kg, maximum 10 milligram per dose. If none of the three options available is not available, then choose one of the following, like intravenous phenobarbital will use 15 milligram per kg per dose as a single dose. Rectal diazepam will use 0.2 to 0.5 milligram per kg, maximum 20 milligram per dose. Or intranasal midazolam will use, or buccal midazolam will use. Intranasal midazolam dose is 0.2 milligram per kg, ma'am.
Yeah, so one thing you have to remember is the anticonvulsant doses, the maximum dose are almost four times the normal.
जी मैम.
So when you say that I gave adequate dose, when you've given only 40 mg levetiracetam, you have to always cross-check. You
Okay.
may be able to give much higher doses and bring the seizure under control. And also, take-home messages would be the intranasal and buccal midazolam availability. If
Okay.
you should make sure that it is, if you are a neuro center, it is available because many a times you will not get IV access, and these are the most handy drugs to use. Continue.
One minute, ma'am. Now I'm next 20 to 40 minutes at the second therapy phase. If there is no evidence based, we have to prefer second line of therapy, like intravenous phosphoenatoin 20 milligram PE per kg, maximum 15 milligram PE per dose. We will give an
What is
intravenous,
PE?
ma'am, phosphoenatoin equivalent, ma'am,
Phenytoin equivalent. Yeah.
phenytoin equivalent. And intravenous, we will give intravenous valproic acid also 40 milligram per kg, maximum 300 milligram per dose. Intravenous levetiracetam we will give 60 milligram per kg, maximum 4500 milligram per dose. If none of the options are available, then choose one of the following, like intravenous phenobarbital 50 milligram per kg is a single dose.
So
When we
what is
start,
this based on evidence? Which trial?
rampart trial.
Asset, phosphenytoin, valproate, and levetiracetam.
uh,
All three were equivalent.
yes ma'am.
Continue.
Now ma'am, in next third phase 40 to 60 minutes, if still is seizure persist in 40 to 60 minutes, we have to start with the third line of treatment, like we have to repeat second line of therapy, or we will add some anesthetic dose of either thiopentol or midazolam or phenobarbital or a propofol or a ketamine, and monitor with the continuous EEG monitoring.
So why
And
is ketamine a preferred choice in status epilepticus? Why does it work when midas doesn't work?
ma'am, basically ketamine is a 1 minute ma'am. Ma'am, ketamine is not a part of standard initial therapy of status epilepticus, but it may be used as an adjunct in refractive or super refractive status epilepticus because due to its NMDA antagonistic action and its advantage, it has a minimal respiratory depression and it maintain the blood pressure also.
You said its action is an MD antagonist action.
Yes, ma'am.
Agreed. But why is when benzos are not working, why is ketamine working? So what exactly happens at cellular level?
Don't know, ma'am.
GABA receptors go down
Okay, ma'am. Yes, yes,
and
yes.
the NMDA receptors come to the surface.
Okay, ma'am.
That's why ketamine works and benzos don't work.
Okay, ma'am.
Okay?
So, ma'am, in third phase, if still severe persist, we have to intubate the patient and ventilate to maintain the normal PSU2 and PCO2. RSI should be performed, fluid restriction to maintain the adequate systemic blood pressure and the cerebral perfusion pressure also. Now, ma'am, one more important thing: the muscle relaxation stop the seizure movement but not the abnormal cerebral activity. Therefore, in the paralyzed patient, anticonvulsant are also essentials.
Yes. Before thiopentone, do you want to try anything else? What is the problem with thio?
Thiopentone.
It causes comatose situation for many, many days, almost weeks.
Okay, ma'am.
Even the brainstem reflexes may be absent, and that state will continue for many weeks. Especially, you have to be careful with the electrolytes.
Okay, ma'am.
Potassium can go to dangerous low levels, and toxicity of thio will increase. So, you can use inhalational anesthetics. How do you
Okay, ma'am.
use that in the ICU?
I will use ketamine and
Inhalational anesthetic.
sorry, ma'am. Isoflurane will use and
How do you
sedation will
use it?
use. When we use
So,
via
an anesthetist, you might bring the anesthesia machine in, but usually we can't.
yes,
So,
ma'am.
how do you get?
Definitely.
Have you
When
heard
we
of anaconda?
ma'am, anaconda, ma'am, we have, ma'am, but we have lots of less chances to use as a anesthetic agent in this
I
case, ma'am.
have used it twice.
Yes,
So,
ma'am.
with anaconda, you still need a scavenger, but you don't need the whole anesthesia backup. That machine and all you don't need.
Okay, ma'am.
But the problem is, you can get burst suppression easily.
Okay.
But when you start coming down, it will cause again recurrence of seizures. That's very common. So if you have the possibility of using an inhalational anesthetic, it should be used way ahead.
Okay, ma'am.
And when you're kind of backing off from the inhalational anesthetics, you should have other backup plans. So IO should be a backup plan when you're coming off the inhalational anesthetic.
Okay, ma'am.
Continue.
So, ma'am, now we came to the management of refractory status epilepticus. In case of refractory status epilepticus, we have to do the continuous EEG monitoring, and along with the IV midazolam bolus followed by infusion of zero point 0.1 milligram per kg per hour. And if still seizures is there, we will use a propofol infusion at 1 to 2 milligram per kg loading dose over a 5 minutes, and then we'll add a ketamine infusion also if still CH is there in a dose of 0.3 to 3 mg per kg followed by 0.5 to 0.5 mg milligram per kg per hour infusion. We'll also add a IV pentobarbital 5 milligram per kg over 10 minutes followed by 1 to 5 milligram per kg per hour for 24 hours if still CH is persist, ma'am. Now, ma'am, the alternate treatment of status epilepticus, refractory status epilepticus like vagal nerve stimulation, ECT, deep brain stimulation, ketogenic diet, or hypothermia, and the resective surgery. Now, ma'am, what is the important role of steroid in status epilepticus, ma'am? Steroid has no established role in routine treatment of status epilepticus and are reserved for only for the specific etiology like autoimmune encephalitis, NORS, fires, or the cerebral tumor related seizures because of lack of evidence and potential risk of adverse effect, ma'am. And the role of ketamine in status epilepticus according to AN and ES guideline, ketamine is not a part of standard initial therapy for status epilepticus but may be used as adjunct in refractory or super refractory cases due to its NMD antagonistic action. It is used when failure of benzodiazepines or the second line of AD conventional anesthetic, especially useful in NORS or fire like seizures or hemodynamic unstable patient. It does not causes hypotension like propofol causes, and its advantages it has a minimal respiratory depression and it also maintain a blood pressure, ma'am. It has
So
limitation of use.
tomorrow,
Yes, ma'am.
if your patient has a seizure, you've given benzo, it's not working,
We'll give a
and
ketamine,
you've
ma'am.
ended up tubing the patient. So along with the anticonvulsants, what will you start?
Along with the anticonvulsant, ma'am.
So you've started him on levetiracetam, he's already on phenytoin, you've added valproate, he's still
Okay, ma'am.
seizing. Now what will you add?
We'll add propofol along with
I would add ketamine.
Okay.
because he's already on midazolam. He is likely to have hypotension.
Yes.
Ketamine is shorter acting. When I want to wean off, it is easier for the patient to wake up, and I have an assured hemodynamic stability.
Okay, ma'am.
So, and even cost-wise, ketamine comes up less expensive compared to propofol.
Okay, okay, ma'am.
Continue.
Now, ma'am, role of any kind of surgery in status epilepticus. Ma'am, surgery has no routine role in status epilepticus and may be considered only in the super refractory cases with a well localized or the surgically resectable electrogenic foci or identifiable structural brain lesion, such as like brain tumor or any kind of abscess or any kind of focal refractory epilepsy presenting. It requires
So, how do
multi.
you define focal refractory seizure, epilepsy?
Ma'am, it's a
Like your patient,
yes, ma'am.
he had a normal CT and MRI,
Yes, ma'am.
but he's continuing to seize. All your medical measures have not controlled it. Now you're thinking of seizure, surgery.
Yes,
How will
ma'am.
you define what surgery to do?
Ma'am, MRI, CT, both are normal, ma'am.
Hmm. So you have ruled out any space occupying lesion which can be excised and seizure can be controlled.
तो मैम स्पेस ऑक्यूपाइंग रीजन इज मतलब तो दिखेगा ना मैम उसमें सिटी में.
So it is not there.
ओके.
But now medical therapy has failed and you have to do a surgery. How will you define what surgery to do? For that you have something called ictal MRI
ओके
or
मैम.
ictal EEG.
इक्टल एज.
So you actually cause an seizure and then look for the uh, part of the brain where the seizure activity is localized.
यस मैम.
And then you resect only that much.
इक्टल सीजर मैम. ठीक डन मैम.
In contrast to seizures, long-standing seizures in which over months and years you have given a lot of anticonvulsants and still patient is continuing to have episodic seizure.
यस मैम.
There you do more destructive like amygdalohypocampectomy. Those kind of dissection surgeries are done. The two lobes are kind of dissected off. Those are more destructive type of surgery.
ओके मैम.
You understand?
यस मैम.
Yeah, continue.
Now the ma'am role of immunosuppressant in status epilepticus. Ma'am, immunotherapy like steroid or IVIG or plaques are not a part of standard status epileptic management, but it is recommended in suspected case of autoimmune or the inflammatory epilepticus, especially in the refractory status epilepticus knots and fires. Early empirical immunotherapy like steroid IVIG is recommended without waiting for antibody confirmation in autoimmune encephalitis. Like the first line immunotherapy start within 48 to 72 hours, which include the IV methylprednisolone or IVIG or plasmapheresis. The dose of methylprednisolone is 1 gram per day for 3 to 5 days. Dose of IVIG is 0.45 gram per kg for 5 days, ma'am. If refractory status epilepticus, escalate therapy, second line immunotherapy along with the anesthetic infusion of ketamine and thiopentone. And the second line immunotherapy, which include rituximab and cyclophosphamide. These are the different line of immunotherapy we'll use during refractory seizures like plaques or corticosteroid, IVIG. Second line immunotherapy which includes cyclophosphamide, rituximab, and the mycophenolate and azithromycin. Now the role of diet modification in status epilepticus. Dietary modification had no role in routine management of status epilepticus, but ketogenic diet is recommended as adjunctive therapy in refractive and super refractory status epilepticus, especially knots and files, ma'am. And it should be started early, often within 3 to 7 days of ICU admission. If seizure persists, monitor regular ketone level, electrolyte and lipids and acidosis. Ketogenic diet increase ketone bodies, which is alternative brain fuel, increase GABA receptor and decrease glutamate excitability, and also having some anti-inflammatory effect.
So
Other
this is
dietary.
very effective in pediatric patients with different metabolic disorders.
Okay, ma'am.
There, the ketogenic diet is found to be very effective. Continue.
Well, we're also having some fourth generation anti-epileptic drug like brivaracetam or perampanel or eslicarbazepine, cenobamate and cannabidiol and clobazam and topiramate and oxycarbazepine with having some mode of action. It
So
has
when will you think of all this? Your patient was on levetiracetam 40 mg per kg.
yes, ma'am.
Next, will you think of brivaracetam or valproate in LMIC situation like India?
Well, we use brivaracetam, ma'am.
What is the cost of brivaracetam?
I don't know, ma'am. Cost.
Exactly. So these drugs have to be continued for a long time.
Okay.
You send a discharge with brivaracetam, he buys it for a week, and next week he doesn't have money. What is going to happen?
Okay.
Compliance is not there. Patient will come back with a, if he had come with refractory seizure, next time he will come with super refractory seizure.
Okay.
So you have to be very careful when you send off with the prescription. Give
Okay.
something which they can afford. Even if it is two or three combination of pills, if they're likely to take it, send them on that rather than the newer agents which are much more expensive.
Okay, ma'am.
Thank you.
Ma'am, this is a trial, ma'am. This is a rampart trial. It's a anti-convulsive medication prior to the arrival trial. It compare intramuscular midazolam and IV lorazepam for treatment of status epilepticus by the paramedics before reaching the hospital. This study is important, ma'am, as we know that the IV lorazepam was considered the standard treatment, but in real emergency, IV access is often difficult. So, any kind of delay in drug delivery worsen the outcome in epilepticus patient. So, IV midazolam can be given quickly, easily in the ambulance or in pre-hospital setting, or it may be delivered by auto ejector. So Rambert trial basically it's a double blind randomized clinical trial conducted by EMS or paramedics. They include adults and children with ongoing seizures of more than 5 minutes. Patient, it has a two group, ma'am. One group will receive IV midazolam 10 mg plus placebo, and the other group will receive IV lorazepam 4 mg and the placebo. So it has primary outcome, ma'am, is to absence is to termination of seizure before the arrival in emergency without use of any other rescue therapy. So IV midazolam performed better because intramuscular injection was given faster and IV access took some time. 73.4% individual who receive IV midazolam has termination of seizure before arrival in emergency, ma'am. But statistically, they are not statistically significant. There is no difference in seizure recurrence or the adverse effect. And this slide, ma'am, summarize the adverse effect seen in the landmark Veteran Affairs Status Epilepticus Cooperative Study published by Daniel M. Terriam in 1998. The study compared commonly first line of drug for convulsive status epilepticus, in which the N is the number of patients who receive each drug, that is 97% individual receive lorazepam, 91% individual receive phenobarbital, out of which 14.4% will have a adverse drug effect like hypoventilation, 27%, 27.8% having hypotension, and so on. This is again slide which summarize a treatment response in two type of status epilepticus. One is overt status epilepticus and other is subtle status epilepticus. And first line of agent having 55.5% rate of response to treatment. Second line to the overt status epilepticus and 14.9% the subtle epilepticus and so on. And the next in non-convulsive status epilepticus treatment, it must be treated quickly, although the urgency is not as great as convulsive status epilepticus, but the diazepam and the lorazepam are both effective in treating complex partial motor or absent status epilepticus. Response to benzodiazepine may be helpful in confirming the diagnosis. Patient should also be started on anti-epileptic medication appropriate for long-term management when we given as a loading dose. Valproic acid is a ideal drug for absence epilepticus and can be given intravenously of dose of around 15-20 milligram per kg per day.
So what does that culminate for us in the ICU? Suppose you have someone with a focal seizure, not GTCS,
Yes, ma'am.
and his mentation is normal.
Yes, ma'am.
What will you do?
Ma'am, is meditation is normal or GCS is a normal
He's having
condition?
focal seizures, not GTCS.
Focal seizures. Ma'am, focal seizure will give us simple first line of drug.
So many a times, focal seizure is not broken with the small doses of midas. GTCS is more responsive compared to focal seizures. And
Yes,
if the
ma'am.
mentation is high, you have to weigh the benefit of maintaining the airway and giving definitive anticonvulsants, adding a new agent, in comparison to giving an infusion of benzodiazepine, where the GCS may go down and you will have to put him on a ventilator. And in
Okay,
our
ma'am.
experience, we found clobazam very effective in breaking focal seizures. IV form
Clobazam.
is also available, so a
Okay.
loading dose can be given and then followed up with oral. Usually, they are very refractory to midas.
Okay, ma'am.
Continue.
So patients should also be started on anti-epileptic medication appropriate long-term management given as loading dose is appropriate. Valproic acid, the other drug of sense of this is already done, ma'am. Finish, ma'am.
What did you learn before I ask others?
Ma'am, I learned कि first of all when patient came to emergency we have to rule out the rule out the patient having any history of seizure with a missing dose first of all, and then send the all the relevant investigation, and we rule out the what kind of seizure patient have, the focal seizure or the generalized seizure, so treat will accordingly. And first of all we have to control the seizures of the patient and then send for the further investigation. These all are things, ma'am.
Anybody has anything to ask or contribute, please? If nobody has anything, thank you very much, Neeraj. It was a good presentation. The
Thank you, ma'am.
take-home message is first ABCs
Yes, ma'am.
and light stroke here also time is brain. The
Okay, ma'am.
sooner
Yes,
you
ma'am.
break the seizure, the better the outcome.
Yes, ma'am.
The more the seizure lasts, it's
More
going
the
to be more
brain
difficult to control.
control, ma'am. Yes, ma'am.
And if you have uh, inhalational anesthetic possibility, use it upfront rather
Okay,
than
ma'am.
leaving it for the last.
Okay, ma'am.
And monitoring has to be adequate, monitoring has to be done. If you don't have EEG, that is not the end of it. You can have other bedside things to use, like BIS and NIRS, etc.
Done, ma'am.
All right. Thank you.
Thank
We
you,
will
ma'am.
meet back up in next fortnight with another session.
Thank you, ma'am.
Thank you.
Thank
Good
you, ma'am.
night.